Hello, friends, and welcome back to another episode of the Concussion Nerds podcast. And today we are welcoming a guest and a new friend of mine who really we're meeting for the first time today. And I'm going to share how this came about in a second. But Dr. Jimmy Pang, please tell me I said your name right.
You got it.
Okay, perfect. I was like, we should have clarified that before we started. Welcome to the show. Guys, you've heard me talk about before about sometimes we just need to take the first step and we just need to ask the question. And that's how this podcast came to be. Honestly, I'm going to read Jimmy's bio here in a second, but Jimmy followed me on Instagram. Pretty sure I sent him a message saying, thank you so much for being here. And he asked if I ever have guests on the show. And I said, I absolutely do. And send me an email. And so that's where today is coming from. And I love that. So thank you, Jimmy, for expressing interest in being here and wanting to share your passion with my listeners.
I'm just happy to be here. So thanks for having me. Super excited. Yeah.
My pleasure. I'm going to read his bio so we all know who Jimmy is here. So Dr. Jimmy Pang is a physical therapist specializing in vestibular and headache disorders. So I know this is going to hit a chord with many of you listening. He has a particular passion for treating concussions as they represent the perfect intersection of both these areas. His decision to pursue this specialty stems from his own journey with chronic migraine and chronic pain, giving him a unique level of empathy and understanding in his care. So, Jimmy, thank you again for being here today.
Thank you.
And like my listeners, I would love to know more about you, especially when you shared that your passion, this comes from your part of your own journey. Who is Jimmy? Where did this passion come from? Share a little bit of your story with us.
Yeah, sure. So, I just want to start off by saying that I really am very excited to be here. It's really nice to be in a space, because there are many clinicians out there who choose to pursue this specialty. And it's really nice to talk to someone who does. And I work alone. I don't have any coworkers. So it's really nice that I have someone and a colleague, perhaps a mentor that I could bounce ideas off in the future.
Yeah.
But a little bit about my story. So let's roll it back. So when I went to PT school, when I first started, I think I was like most people. I wanted to do orthopedics. I wanted to work with sports injuries, stuff like that. And then it didn't take me very long to realize actually neurology was way more interesting. So I went to neuro, and then for the longest time, my favorite population was treating stroke patients.
Okay.
Which is naturally very physically demanding work, very rewarding, but very physically demanding. And then in 2017, I actually became a chronic pain patient. So it started with low back pain, and then eventually kind of spread into my foot. And then I started getting pain in my elbows and my arms. So a lot of central sensitization. And that happened for 2 years, and I was still pushing through. And then I actually woke up with my first migraine. So it happened overnight.
Okay.
And then I've actually had a headache ever since. So it's been about 6 years.
You currently still have a headache every single day?
24/7. Yeah. 24/7. 6 years. With facial pain and autonomic symptoms. It's a pretty long story. There's a lot to unpack there.
Whew, that's going to be a whole other thing. Can I ask? Oh my gosh. You could just see me be like, oh shit. I'm going to take a wild guess. You've gone through the traditional Western medicine route of this medication, that medication, this physical therapist, seeing chiropractor. I'm going to guess you've done all the stuff.
Pretty much. Yeah. Yeah.
Okay.
I think I'm lucky. I work in this space as a therapist, so I have some discretion, right? So I can tell when I'm getting good care. Sometimes it's a double-edged sword. It's like, in your head, you're like, well, I would do this differently, but that actually doesn't help. Sometimes you just need to delegate to someone else. But kind of going back to that, we can kind of loop around to that later. But so, I was on disability for 2 years, and, the rest of the pain in the body wasn't good either. And so I think I've come a long way. I went from being unable to work to now running my own practice, my own business. I still have some issues. But what really drove me to concussion and headaches and all this is with the chronic pain, I wasn't able to sustain the stroke rehab anymore. It was just getting way too tough on my body, which was very disappointing. And I was like, I got to switch it up. This is not working. I was like, I really don't want to do orthopedics. It's not my passion. It's fun here and there, but it's just nowhere near as gnarly as neuro diagnoses are and treating neuro populations are. I love that aspect of it.
Yeah.
But then I thought about, well, I have this neurological disorder. I have migraine. I should also, there's more to unpack here. I did, before all my chronic pain started, I was a competitive Muay Thai fighter as well. So I did have a history of concussions.
Okay.
Yeah. So this might end up being a pretty long podcast. But yeah, and then so I was like, this is really cool. And then I decided to transition and I took some more courses in vestibular and concussion rehab
Yeah.
and migraine treatments. And now I'm really loving it. I'm so excited about this new direction that I've decided to take a few years ago. And even
Yeah.
though, the road was fraught with disappointment, I really feel like now, like, wow, I'm actually very excited about my work.
That's
Yeah.
amazing.
Yeah. This is
Me
me. I'm very monotone, but this is me excited. So,
This is your site. Thank you for you can see the smile on his face if
yeah.
you're watching the video.
Yeah.
And I love that. Thank you for sharing that. It's funny. So I started in stroke as well. I think a lot of us in neuro start in stroke, to be
Yeah.
honest. So I'm an advanced bath practitioner and insanely hard on physical. And I remember my mentor being like, because I would finish my shift and I'd be in tears. I was in so much pain.
Yeah.
I was a new grad. I was like 5 months into practicing, and at the end of my shift, I'm like in such pain, and mine was my mid back. I'm in
Uh-huh.
such pain. I'm crying, and I remember my mentor being like, "Natasha, I'm a little worried about you." And then when I moved to Nanaimo, I remember I don't even know what I did. I did something to my wrist. I literally woke up with like the worst fucking tendonitis in the world. I couldn't move my wrist without pain. I forgot all this stuff until he started talking. And so I was splinted and I was acupuncturing myself. But same thing, at that point in time in my caseload, I was seeing orthopedic and I was seeing stroke and I'd been working with concussion for a couple of years. And I remember when that happened, I had to cancel my entire caseload except my concussion clients because I couldn't physically do the job of my ortho and my strokes. And I remember just being like, oh, feel like I need to diversify my case a little bit more. And I loved working with all of my clients in those populations, but that was kind of the start point into doing more concussion. And then similar to you in that piece of like, once I started getting more into it, like
Mhm.
everyone knows now, like I fucking love it.
Yeah, the stroke to concussion pipeline is very strong.
It is.
Yeah,
Yeah.
yeah,
Very strong indeed. I could say the vestibular to concussion pipeline is also very strong.
yeah,
Yeah. I feel like you come from very commonly, I'm going to say one of those realms, or I could say
mhm.
this too, orthopedic too, when you look at ortho with athletes, though, more than anything. So, how long have you now been working with kind of concussion and migraine and headache?
3 years,
Okay.
about 3 years.
What is your favorite part about working with this population?
They're pretty disabling disorders, right?
Yeah.
So I think, of course, there's the reward of helping somebody kind of reclaim their life again, right? Having somebody get better and get back to things
Mhm.
they love. It's really personal for me. It's
Mhm.
something that I deal with and I've dealt with. So, every success story, I'm not just happy for the patient. It's like I feel like I'm fighting my mortal enemy on a larger scale. Like,
Okay.
like I want to get better. I want my patients to get better. I really want to spread awareness about headache disorders. But I think most of all, what I really enjoy is the creativity because they're such interesting disorders. And like I mentioned, like they can be like just totally like gnarly, like
Yeah,
just like
they're
really weird
debilitating.
findings, debilitating,
Yeah.
just weird findings. And really is like a complex puzzle that you can figure out. And it's just a lot of satisfaction in doing that.
Can you help our listeners? Because I definitely know there's some people that are like, I don't know if this is a headache. Or I don't know if this is a migraine. So, can you help our listeners by differentiating between what is a headache and what is a migraine?
Yeah, that's a great question. And the more research that comes out, actually, the lines are getting blurred more and more.
Okay.
So I typically think of migraines as they're just much more debilitating and disabling than headaches. So typically, migraine's going to come with other neurological signs. So I think that's the big tipping point. So I think a lot of us are familiar with the classic symptoms like sound sensitivity, noise sensitivity, but migraine is much more complex than that. Migraine, there's a broad spectrum of what migraine can produce. So I'll talk about myself as the first example. So I fall into a class called the atypical migraine variants. And so, it's complicated when they have a catch all basket like that, atypical. And so I don't get light sensitive, I don't get noise sensitive, but I have this 24/7 headache. I got a lot of autonomic symptoms. So, ear fullness, sinus congestion. I get ptosis on this right
Mhm.
eye, and I have a lot of facial pain. And then actually when it gets really bad, I become ataxic. So I have episodic ataxia. It's happened three or four times. I haven't had one in over a year. So it's pretty scary. And then, I think a lot of us are probably familiar with vestibular migraine. right? So migraine causing a central disorder, causing all these vestibular issues in people. And then there's some of the really obscure ones like abdominal migraine, where the migraine is actually, you know,
That's a new one for me.
yeah, so the brain is so haywire, it's starting to affect because, with the brain and the gut, right?
Mhm.
Gut brain axis is pretty interconnected. So abdominal migraine means that the neurological kind of, what's the word? Just all that overactivity in the brain is actually creating abdominal symptoms. So it can
Okay.
lead to stomach pain or even, bowel disruptions. We also have something called hemiplegic migraine. So hemiplegic migraine, it literally is just what it sounds like. It results in weakness on one half of the body, just like a stroke,
I
presents
think you're
just like
having
a
a
stroke.
stroke with that one. Yeah.
So, yeah, so migraine is very complicated. We're learning more and more about it every day. It's
Mhm.
actually the second leading cause of disability in the world, just behind low back pain. So,
Oh, wow.
yeah,
Crazy. I think it's important to note too with migraine, you don't actually have to have a headache or head pain to have a migraine,
correct.
right? So you unfortunately do.
Yeah,
And many people do, but you don't have to have a headache or head pain to have a migraine.
correct. Yeah, yeah. I wish more people knew that. I mean, I think they're finally starting to update the diagnostic criteria for vestibular migraine. I'm blanking on the document, but they finally
That's
added
okay.
criteria that says like just earphone. People classically wouldn't think of that as a migraine, but that could be a diagnostic criteria instead of the headache. Just if you experience
Hmm.
earflugs instead of a headache, that could be an indication that's pointing towards migraine.
Okay.
Yeah.
So, I mean, I know when I think of migraine, I think of a bucket theory approach to migraine, but, and we can talk about that after if you want. But tell me when you see a client and migraine is their big thing, like, how do you approach that, right? A lot of physios, when they see migraine, are like, oh, fuck, I don't know what to do. So
Yeah.
I know where my brain goes and I know where our assessments go and I know where we go, but tell me what like, you're in San Diego, right? So there's
Mhm.
people you can serve that I obviously can't. So when someone comes to you and they're like, I'm dealing with headaches and migraines, where do you go? Where does your brain start to go? Where do you question? What are the things you want to know and understand to be able to support this client?
Yeah. Great question. So when I get a migraine client, I mean, first thing, I want to establish, and this is my very strong opinion, that migraine at the end of the day is always going to be a central disorder, right? It's a disorder
Mhm.
of the brain. We don't have a cure, right? And then, so I think you mentioned the bucket theory. I think we're referring to the same thing when I say like threshold theory.
Yep.
So, threshold theory. So, for those of who are listening who aren't familiar, we have triggers in migraine, and then you have a threshold. And then, if you have too much environmental stimulation, like triggers adding on each other until they reach a peak and go over the threshold, that's what creates the migraine episodes or it causes symptom exacerbation. And then when I think about it, so when I get a patient who has migraine, my goal, I think traditionally a lot of people they start thinking about, okay, a lot of the emphasis is on the trigger. Like get rid of the triggers, get rid of the triggers. And then you'll find that for a lot of patients that becomes very stressful very fast, right? You're asking people to track things like barometric pressure with weather changes, you're asking them to track diet, sleep, like all these things go a little haywire. So for me, my goal is to increase the threshold, right? Give them more capacity for their triggers so that they can get back to doing, regular things that they want to do. And then, so the question is, what symptoms, what presentations, what deficits are they presenting with that I think is going to, that is essentially lowering the trigger the most? So if they have a lot of cervical deficits, because migraines is like a vicious cycle, right? So the migraine's going to create a problem, and then that problem is going to get worse, and then that problem is going to lower your threshold and then further exacerbate, make you more susceptible to more migraine attacks, and it's just this
Okay.
vicious cycle that continues. So we need to break that cycle at some level. And so what we want to do is we want to see what deficits they present with, and then so I think a lot about cervical things.
Okay.
So migraine, has a very strong association with creating cervical deficits, muscle tension, proprioceptive deficits. And so I definitely want to, and generally in my experience for migraine, the more cervicogenic components they have, the better they're going to do. That's just my own anecdotal experience. And then also we want to look at vestibular deficits they might have, ocular motor deficits they might have, and then kind of trying to piece it all together and just really trying to hone in on what you think is going to increase their threshold the most. if that makes sense.
Yeah. Well, no, it makes complete sense. So
Yeah.
it's similar to what we do over here. It's that piece of, and I always say to clients, I mean, the migraine is the symptom, right? The migraine is the symptom, just like the dizziness is the symptom. The headache, while there is, when we look in the concussion space, while depending on the research you read, there is a phenotype or a subprofile or a, however you want to call it, of a headache / migraine, it's still a symptom. So when you look at a lot of the stuff in the concussion world and the research around post-traumatic headache or post-traumatic migraine, I just like knocked my microphone out of the way. It's like a lot of the go-to treatment in the medical world is medication, right? To me, and I preface this with like, I'm not against medication if it helps you. I'm really not. But a migraine and a headache is a symptom. And so as much as we can, which is very similar to what you were saying, Jimmy, is that we want to find the root of what is driving that symptom as much as we possibly can. So when it comes to migraine and we talk about triggers, right? We know that there are triggers that will increase you going over so when the bucket theory is like you have this much capacity, and then when you lose that capacity, you overflow, you cue the migraine basically. And we know that there's triggers that will into that. So if some of the trigger is stress, if some of the trigger is that element, we need to pay attention to that. But also when you look at it and you look at migraine, for so many people, there is, I say, like a musculoskeletal component. So the cervicogenic stuff you're talking about, 1000%. There's almost always a neurological component.
Yeah.
And typically with migraine, there's a big brainstem component.
Yeah.
And so when we're looking at the neurological component, there's a nutritional component, right? For some people, those migraines will get decreased if you, like, I had a client, literally, we removed gluten from her diet and her migraines decreased by 50%. Now, I'm not saying like, I was like, holy shit. Not something I would ever expect to change to that significant capacity ever. But I can tell you for myself personally that if I stopped eating gluten because of headaches, and honestly, dairy is another thing that fuels headache, not migraine, headache in me, right? So there's, for some people, there's a nutritional component and then there's a hormonal component.
Correct.
And so when Jimmy's talking about finding those triggers, it's kind of that piece of like, what is the biggest component for you? And in that neurological lens, this is where you guys like, I guess I care about your diagnosis, but I don't care about your diagnosis because I'm not treating a diagnosis. Now, do I need to know that diagnosis? Because yes, it's going to tell me things about outcomes. It's going to tell me things about certain medications. It's going to tell me things about prognostics. And yes, it does matter, but it's not going to impact overly what my assessment looks like, to be honest. I mean, I say that from a migraine concussion standpoint. Okay. Obviously, a stroke comes in, my assessment's going to look a little bit different than my concussion. But from that, when you think of that bucket and you think of the musculoskeletal piece, the neurological piece, then hormonal and the nutritional piece, I'm not going to do shit for testing hormones, but I am going to ask you questions in your history about when you notice your migraines show up, particularly with women.
Yeah.
Right?
Yeah.
Nutritional, I'm not in my scope of practice. And I'm going to say, have you ever tried an elimination diet? How'd it go? I'm going to refer you to a naturopath or a functional medicine provider. But MSK and neurological, I sure as heck am going to dive into.
Yep.
And so like Jimmy, we're going to look into the cervical spine. Huge. And there's so much correlation between TMJ and cervical spine too.
Yeah.
And that relationship. And when you start asking like our migraineurs or our cervical spine, like, do you clench your jaw? Oh yeah, all the time. Yeah. Right? Do you clench your jaw, Jimmy?
Yeah, I do. I grind my teeth at night too, and it's so bad. My night guard is actually starting to crack. So,
oh, good God. Yeah. That's no good. And then, like you said, from a neurological piece, that's where you guys, whether you're listening to this or not, like you want to go through your multi-systems assessment, right? You want to look at the vestibular function. You want to look at ocular motor. You want to look at autonomics because you need to find out what's working in this person and what's not. Right. And so it's so funny sometimes because when clients will come for an intensive who are of concussion, sometimes they forget to tell me that they have migraines and sometimes they don't. And then I'll just get an email or I'll get an email like, I haven't had a migraine all week and I normally have like 3 a week. And I'm like, oh, that would have been good to know. But yay. So yeah, I think this is an important piece. And I love that whether you realize it or not, the fact that you are doing some multi-system pieces to figure out where the deficit is and where you can improve function. Because the way I look at it is the more we can improve function in these areas, so in these buckets. So again, I think of buckets, triggers, threshold,
Yeah.
where we can improve function means there's less error, means
Mhm.
there's less drive into sympathetic activation from a nervous system perspective, which means you increase your capacity in your threshold, which then
Yeah.
means you have more room for stress, you have more room for these other pieces,
Yeah.
right?
I love what you said about the diagnosis piece. Like, I very strongly agree with that. I think that's the beauty of being a therapist, really. We're not pigeonholed with our diagnoses, right? Our diagnoses are kind of these, it's like a large web that we develop.
Yeah.
Like, it's almost like a collage. We make this collage of all these impairments, and that's your diagnosis from a PT perspective, not so much like this word. No,
Absolutely. Well, think about, I mean, you must see this. How many people do you get referred to you that have BPPV that don't actually have BPPV?
a lot,
All the time, right?
all the time. Yeah.
Because most physicians just equate vertigo with BPPV.
Mm.
And they come in front of you and you're like, "Sweet." And then you're like, "This is not BPPV."
Yeah, I know.
Right?
Yeah.
I love that you're like, "I'm gonna do this assessment. I'm gonna look at these different systems. I'm gonna find the deficit. I'm gonna help, put this thing." How much attention do you spend, especially from the migraine population, because headaches is a whole other thing, but how much attention do you spend educating on the lifestyle factors that can contribute to migraine and those triggers?
Yeah. So, lifestyle factors, there's so much, right? We kind of mentioned the nutrition piece. Also a big trigger for a lot of people is when the weather changes. So if it gets
Mm.
cloudy, thunderstorms, the changes in barometric pressure. So there's a lot to track. But generally speaking, I stick to my wheelhouse. And, nutrition for me, I find it's hit or miss for people. And for some people, it can almost make it worse because they become so hyper focused on not eating anything pretty much. So that's very stressful. But for me, my main priorities with patients is sleep and stress, right? I think if you can kind of handle these two things, get them in a better place, then, that bucket is a lot less filled with water by a
Mhm.
substantial amount. So sleep hygiene is really important. I talk about that all the time with my clients. I'm like, yo, guys, you got to break up with your phone. Like, you can't be on your phone, like on TikTok for 3 hours before bed every night. You're not doing
I'm
yourself
so
any
bad.
favors. So try to cancel like that, So I guess that's a form of couples counseling, people on their phones. We do a lot of psychological work as PTs, quite frankly.
Oh, for
Right.
sure.
So much. Yeah.
Anyone who says we don't, we
Yeah.
do tons.
Yeah. So the phone thing is really big, sleep is really big, and stress is really big. And then if I feel like they're doing a good job with those and they're still having a lot of problems, then maybe we start looking into the other things.
So, am I hearing this right that you will start with the lifestyle factors first to
Mhm.
see if you can get some wins there, and then you'll shift more into the MSK, or are you doing it simultaneously?
Simultaneously.
Okay.
Yeah.
Okay.
Simultaneously.
Okay.
Yeah. I mean, those lifestyle things are also just good for you. So,
Absolutely. Do you
yeah.
know what I say to our concussion clients all the time? Or like, or most of our concussion clients is I'll say the things that we teach you that you need to do to literally function in the day, right? And these are the things we're talking about. These are like, this is the sleep hygiene. This is the like, get off your fucking phone 2 hours before you go to bed. This is
Yeah.
the like, make time to connect with people, have like, breathe. Let's teach you how to breathe properly. Like these things and these skills that are so important to our concussion clients, or I'm going to say we put our migraines in there too, that are so important because it's what gives them capacity to even show up a little bit as we deal all the other stuff. I always say to them, these are the same things that someone like me uses to optimize our function. And I'm very honest, like this is an area that I'm hugely passionate about, but like I don't have PCS. I've never had PCS. I've had one acute concussion that may be resolved in 4 days. Right? Like, I don't have that. I was the family member, and my experience comes from working through trauma. So I say the things that you learn, these skills, these habits that you learn and put into your lifestyle as someone on a concussion healing journey or on a migraine journey, don't stop doing them when you start to feel better because truthfully, they are going to become your superpower because they are literally the things that people who don't struggle are doing to optimize life and function. And I
Yeah.
think sometimes it's an important message to share with people because it's like it just kind of sucks that they have to do it all the time, and I appreciate that, and
Mm.
at the same time, like, they're building a skill set that's gonna serve them for the rest of their life.
Yeah. Yeah, very well said. Yeah.
So when someone wants to work with you, Jimmy, like, what does that look like? Do you own a clinic? Do you do home visits? Like, what does your practice look like, and why did you choose to do it that way?
So my practice is exclusively in-home, and,
Okay.
so, I'm the only provider. So basically, if they go on my website or however they find me, they call that number, it comes straight to me. And I do a free phone consult with them, and then if we decide that it's a good fit and we wanna move forward, then we go ahead and schedule, and then I drive to the home, and that's pretty much how it works over here in SD.
And can you share with us, like, what are some of your client wins? Like, what are some of the experiences that your clients have and those transformations? Because migraine is definitely, I talk to some of my clients and they're like, I have 5 migraines a week. And I'm like, holy fuck, like, you're spending, like, that sucks. And so, what are some of those wins that you see and that you get to celebrate with your clients on this journey?
So actually, I just moved to San Diego 6 weeks ago, so my practice was actually in the Bay beforehand.
Oh, okay.
Yeah, so I'm starting from scratch. But, in the Bay, I had a migraine patient, and she started getting them. She was post traumatic. She started getting them after a car accident. She had a lot of cervical deficits with the whiplash that comes with the car. And I think for me, one big thing for her was that going back to work, she was missing a lot of work. Yeah, she's missing a lot of work and calling in all the time. And I mean, she shouldn't feel guilty. She would feel guilty about it though, right? Like, I should be at work. I should be doing my job.
Mm.
So yeah. And then after that, as she started getting better and she was talking about how she could go to work more and she was doing more traveling and more trips, that's something that was really cool to see.
Yeah, that's awesome. What do you have? Obviously, there's people listening to this that deal with migraine. What do you have for words of advice, wisdom, hope for people who are struggling with migraines that might be listening to this?
Yeah. So, first of all, I'm sorry you're dealing with what you're dealing with. It's very disabling and very distressing. And there's actually a lot of stigma against migraine. People don't take
Mm.
it seriously. But like I said, it's the second leading cause of disability in the world and doesn't get nearly the attention that it deserves. So, I think I want to start out with that. But messages is hope. I think when it comes to migraine, I don't think people realize how many options they actually have. You have
Elaborate on that for me, please.
Yeah, you actually have so many options. And I'm not going to try to sugarcoat it. You're going to try a lot of things and you're going to fail at a lot of things. That's just kind of the nature of it. But as you kind of go through things, that's how you find out whether something is working for you or not. And then if you need to move on to try something else until you find that thing that really works for you. So I think that's really important. So we can talk about different things, therapeutically. There's a lot of, from our standpoint, it took me about 5 years before I really found something that I was like, whoa, this made a huge impact for me. And that was actually vision therapy. That
Okay.
made it huge. So I started going to the vision therapist. And, just based off that, I had like a 40-50% improvement. And then looking at the pharmaceutical side, you know, we're actually in a pretty exciting time with migraine right now because we have the new medications, the new CGRPs, which the first migraine preventative medication that was developed specifically for migraine. So previously, all the preventative migraine medications, they were made for something else initially and then used in migraine. So for example, we have verapamil, which is actually a blood pressure medication, the tricyclic antidepressants like amitriptyline, but now we have like this medication. It's like, oh, this was actually made for migraine, and it only came out in 2018. So that's really exciting. And then there's a whole host of medications you can try. Unfortunately, when it comes to migraine, I do think a lot of times pharmaceuticals need to be on board, especially if you're a chronic migraine or you're having more than 15 headache days a month. Then yeah, I think it really is part of the equation. I think we need it to bring you down enough that you can respond really well or better to the physical therapy and
Mhm.
you have a higher tolerance for exercise to be able to do your home exercise program. But I went off on a huge tangent there.
That's
But
okay. I tangent all the time.
yeah, but there's a lot more hope than you think. There's a lot of things you can try. Don't give up. It can get better.
Hmm.
Mhm.
I'm gonna like wrap that in a nice little bow, and then I'm gonna go on a different rhythm. That piece of when you're looking at options for the listeners is pharmaceuticals is one option because the person you go see when you're dealing with migraines is your general practitioner, and then you typically get referred to a neurologist or a headache specialist. And for many of those types of practitioners, those physicians, their toolbox to support you is medication. I have nothing against medication, but very commonly they don't recommend things beyond that.
Yeah.
Okay. So if you are someone that is on this migraine journey, remembering that pharmaceuticals is one avenue for treatment. Therapeutically, and there's research to support the use of therapeutics with migraine, you're looking at someone like a physical therapist or an upper cervical chiropractor or an acupuncturist or an osteopath or a craniosacral therapist, right? Someone that has that ability to look at both the musculoskeletal component, aka your neck, or your neurological system. And I'm just going to like harp like a broken record. Please find somebody who does something that looks at multi-systems assessment. So it's looking at everything. So Jimmy made a comment about how vision therapy was a huge thing because he had an ocular motor component contributing to his migraines. Okay. Vision therapy wouldn't work for someone who didn't have an ocular motor component. But
Yeah.
the key of that is understanding from that multi-systems assessment what neurological deficits you are having that's driving that piece of your migraine. Okay. So you're looking at pharmaceuticals, you have therapeutics, both musculoskeletal and neurologically. Having someone ask the questions to look at whether hormones are a component. And then you have to look at lifestyle factors as well, right? So these are different buckets, as I call them, or triggers or avenues or pathways, whatever you want to call it, that all need to be properly explored if you're someone struggling with migraine.
Mm-hmm.
I'm biased. I would start with neurological and MSK because that's my scope of practice.
Oh, I mean, migraine patients aren't seeing us soon enough. That's the problem. Right?
Yeah.
Nothing worse than I do a lot of networking. I meet some neurologists. I'm like, oh yeah, I see migraine, and they're like, what do you do for migraine?
Exactly.
And it's like,
yeah,
I'm not gonna punch you in the face right now, like.
And it's just, it comes back to there's just a disconnect and lack of understanding. Jimmy, you're gonna love the new project we have coming out. I'm not gonna talk about it right now, but we have a new project coming out, you guys, that like it's gonna be fucking fantastic. And I'm so stoked for it. But it's gonna kind of feed on this like whole concept of the disciplines just don't understand what the other one does. And we need to be doing a better job at that. But yes, that piece of all those elements. So if you are a migrainer and the only thing you've tried is pharmaceuticals, explore those other avenues because there's probably something in there that's going to support you. Jimmy, tell me, everyone here knows that I am an avid fan of cold plunging when it's done properly. I'm going to preface that piece for the right people. How do you feel about cold plunging in migraine?
So that's interesting you ask because, I have this chronic migraine and I have fibromyalgia. So I'm willing to try anything. And I've done a lot of Hail Marys in my life. So believe it or not, I actually went to train with Wim Hof in Poland.
That's
so,
cool.
Yeah. So, we climbed up that snow mountain, like shirtless and shorts, and spent a ton of time in ice baths and cold waterfalls. And for me, it didn't help. But for some people, it could be. So I'd say you don't know till you try.
And I'm going to say too, like in that scenario, you weren't just cold plunging, you were doing a Wim Hof style of breathing as well. I'm going to guess. Yeah, you were doing the Wim Hof method.
I was honestly just surviving the whole week.
Got it. That's not okay. That sounds kind of like hell. I love cold plunging and it sounds a bit like hell. For someone with PCS, the Wim Hof method of breathing is so I'm saying PCS, I'm going to lump migraine in here too, but is incredibly challenging.
Yeah.
And in many of those individuals will actually cause dizziness. And so they don't feel safe doing it. And so not everyone, some people love it, but some people it just doesn't. It's not a style of breathing that works well for many of my clients, I find. Jimmy, I feel like I need to send you my cold plunge protocol so you can try it.
Sure. Yeah, sure. I'm down.
Because what we find, and again, not for everyone, and the cold just isn't for everyone. Can totally appreciate that.
Do you guys put your head under or no?
Nope, I don't train to put the head under.
Okay.
The million dive reflex, I mean, we know it's a really powerful parasympathetic stimulus if you put your face in cold water. And when you talk about some of the theories of migraine too, it's this like, it's a big spread of parasympathetic, which then activates the sympathetic to combat. And then what we're trying to do is combat the sympathetic depression that happens in the brain, which is where we'll say to some clients, if you pop your hands in ice water, when you start to feel the migraine come on, you catch it. And you decrease the extent and the severity of the migraine as well as the recovery time of the migraine. Very much so, right? And so same thing too, we use vagal nerve stimulators. So I use the Hula stimulator. I'll drop a link below for those that are actually interested in vagal nerve stimulators. So we use the Virelief, which is a vagal nerve stimulator. It just goes through the SCM. And so for my clients, because we know that there is a nervous system component to so many of the migraines, we bring that stimulator in as part of their usually, again, not everybody, but very commonly as a part of their regular routine. And then we'll use it as a immediate kind of prophylactive when they start to feel a migraine come on. We'll
Mm.
bring it into play. And so it can be a really powerful tool as well, both to help increase that capacity and then to deal with the migraine when they feel it coming. So putting hands in ice water. Some people say you can put your face in ice water too, but I don't like doing that. So hands in ice water when you feel that migraine starting to come on can be really powerful. And then this vagal nerve stimulator can be really good. Again, use it when you don't have a migraine, but then when you use it coming on, that breaks the cycle from making it worse.
Yeah.
And in terms of cold plunging, so when you're looking at the migraine having this autonomic component of the nervous system, cold plunging ultimately it's not appropriate for everyone. How you do it truly matters, but can be a very powerful tool for training the autonomic nervous system and building capacity and resilience in the nervous system. But I find there's a very particular way you have to do it. And just running into cold water is not it. And doing the Wim Hof method, although it can be great for some things, makes most of my clients feel like shit. So I feel like I need to send you my protocol.
Yeah, I would love
so
to
you can try it again.
Absolutely. Yeah. So for those listening, that's just like case in point, there's so many options, right? Like I just learned a ton of stuff that I didn't even know about. So another option for me to try, right?
You should probably enroll in Concussion Nerds, Jimmy.
I really should.
You probably should.
Yeah.
Just saying. It has been a pleasure to speak with you though. Okay, so correction. So you are in the San Diego area now. And so you're just starting up. You had to relocate. We're starting practice all over again.
Correct.
Okay. If people want to reach out to you, how is the best way to do that?
Yeah, so just check out my website, pangphysicaltherapy.com. That's Pang, P-A-N-G. And if you go to the contact part of the website, you'll find my email, my phone number, all that stuff. You can text or call that number. It comes straight to me. Okay. So I'm only licensed to treat in California. I do some virtual, but generally speaking, I try to keep it in person. But, wherever you are, if you're dealing with something like a migraine or chronic headache, or you're a clinician who just wants to bounce ideas, or you just want some input on the care you're getting, I'm really happy to take the call. And, even if we don't work together, I really am just happy to talk to people, give them some guidance, help people, because, I'm part of this headache community. I'm part of this migraine community, and we're all in this together. We should help each other. So, yeah.
You have a big heart, Jimmy.
Thanks.
You can feel it. You can feel it through the screen. I love it. Are you active on social media if people want to follow you there?
Oh, yeah, I forgot. Yeah, please follow me. I'm trying to build that up.
I got your back. Don't worry.
My handle is at Pang Physical Therapy.
Okay, awesome. And we will drop those in the show notes for you below, you guys, as well. And Jimmy, thank you so much for being here. Do you have any final words you would like to say? Yes or no?
No, just thank you so much for having me. I learned a lot, and I'm going to be continuing listening to the podcast. Try to join Concussion Nerds. I'm a little strapped for cash right now, but I will.
You just moved and you're starting a new practice. I can appreciate that.
Yeah, but there's always so much to learn. It's always nice meeting different providers. Just learning never stops.
It's true. Thank you so much for being here. It is the end of the day. It's sunny. I'm going to go to the gym. Jimmy, thank you for being here. Thank you for your passion and your continuous energy to want to learn and do and serve in this space. I think one of the biggest things the space needs is compassionate providers who realize we're always learning. And so thank you for bringing that here and for wanting to lead in this space. So for everyone listening, thank you so much for being here. As always, all the links are below. Come join us. If you are on a healing journey, the link for Concussion Mini School, which is our free program for individuals on a healing journey. We just did a coaching call today on exercise intolerance, and we have a whole library of goodness waiting for you. Link to join us for that below. If you are a clinician, you want to be part of the Clinician's Edge. This is how Jimmy and I actually connected too. It is your free dose of weekly neuro wisdom in your inbox every single week. Your concussion gem, your concussion tidbit, all the things to help you have the leading edge in the concussion space. Until next week, my friends, we will see you then. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.